So, uh, the another author, there is eighth Porpel et al. In 2018. They have also reported, release of the different secondary messengers which are important for the muscle adaptation, like for the muscle as well as the, angiogenetic adaptation also. Like what they have proposed that if you do exercise with the BFR and without BFR, and with BFR there is acute response to resistant exercise with BFR. Like for example, there is increase in the growth hormone increase. There increase in the IGF-1, that is the insulin-like growth factor 1, and VEG increase in the VEGF, that is what we call the vascular endothelial growth factor, and hypoxia inducible factor also, HIF also, apart from the increase in blood vessels. But one thing which they have also seen is there is increased cortical activation during the blood flow resistance training. So this is important because this is help for the prevent the neurodegenerative disease, and also for the improvement of the cognitive improvement will be there. So not only for the muscle but also for the entire CNS and other system, blood flow resistance training has a potential beneficial effect, that can be used for the prevention as well as for a therapeutic purpose in case of the senile Alzheimer disease or other neurodegenerative disease, including it may be what you call the Parkinsonism and other depression and all that stuff. Another point one has to understand is the blood flow regarding whether use BFR or not. In case of the BFR, how much is the blood flow reduction is there? Normally, if you see here in this graph, you can see that in the y-axis there is the blood flow in ml per minute, and in the x-axis there are different conditions like resting condition. The blood flow is here, but when you apply the Katsu, that is restriction occlusion band, you apply, there is significant statistically significant reduction will the blood flow will happen, and they had applied by using a bell of 33 mm wide and 880 mm length, and external pressure was applied based upon a systolic blood pressure like 1.3 into systolic blood pressure. It comes to around what we call 160 to 180 millimeter mercury, and it was released after the exercise, and the flow of the femoral artery was they have recorded, and this is the Katsu. But when you do exercise along with the Katsu, there is slight increase in blood flow is there, because in general exercise has a general increase in blood flow. Because of the general increase in blood flow, because in spite of the Katsu, there is relatively increased blood flow is happening during the exercise because of the contracting pumping action of the muscle also. This is also important not only for the arterial blood flow but also the venous blood flow. As I have already discussed regarding the venous outflow, you are basically restricting the venous outflow in case of the BFR. But after some time, because of the contractile action of the muscle, because of the contraction of the muscle, pressure will build up, and that will eventually can overcome the occluding pressure, and hence pulsatile, or what you call the venous outflow can also happen, because venous has the valve system is there in the venous, and the valve system allow the unidirectional flow of the blood from to the vein from the periphery to the heart. So toward the heart there may be pulsatile flow. And one important point was one has to remember is when you just release the occlusion pressure, when you just release the band, then there is what is called sudden increase in the excess blood flows. This is what is known as a reactive hyperemia. This is very much important to induce the shear stress and the production of the endothelial derived relaxation factor or nitric oxide, and because of the activation of nitric oxide synthase, and nitric oxide synthase, production of the what you call L-arginine into nitric oxide. Nitric oxide is very important not only for the vasodilation but also for so many secondary mechanisms, because nitric oxide has the ability to do different type of the metabolic changes, whether it may be angiogenic related or whether it may be because of activation of the satellite cell and other secondary mechanism, leading ultimately for the overall positive physiological adaptation. That's why shear stress is there during the exercise as well as immediately after the exercise, and blood flow is not 100% occluded. Arterial blood flow is not 100% occluded in case of the Katsu. We are just occluding to a certain percentage of the occlusion pressure, that also based upon the occlusion limb arterial occlusion at a resting condition. So this one has to be, because we are not occluding based upon the arterial occlusion pressure during the exercise. We are just occluding based upon a resting condition. This is important. And another, this author LK Larkin in 2000, they reported in 2012. They reported a several, what you call messenger RNA expression which are related to the angiogenesis related gene expression after acute low intensity exercise. They have performed the exercise of the knee extension, around 40% of the 1 RM, and consisting of the 10 set, and one set consisting of 12 repetition with 1 minute rest interval, and the occlusion pressure was nearly approximately 220 millimeter mercury. And what they have done is they have seen the gene expression comparison between the control where BFR was not given, and where a experimental group where BFR was given, and you can see that the expression, the messenger RNA expression of VEGF, that is what we call vascular endothelial growth factor, is statistically significantly rises. It increased in case of the BFR group, not in the control group, and also the primary receptor which is responsible for the VEGF, that is known as VEGF R2, is also increases, and there is increase in the ISIF1 alpha, that is hypoxia inducible factor, and also neuronal nitric oxide synthase also increase. There is also increase in the inducible what you call nitric oxide synthase as well as endothelial nitric oxide synthase, but it was not, but they were not statistically significant. But the point here I want to say is, because of the BFR, because of the shear stress, because of the so many other mechanisms, there is increase in not only various there is trophic factor not only for the muscle but also for the angiogenic related, and because of that the positive adaptation or positive peripheral adaptation happens, whether it may be increase in the angiogenesis, whether it may be increase in the satellite cell muscle proliferation, muscle activation. So all this positive point happens after the BFR, and also there is cortical activation also. So much importance of the BFR is there. But one point which I have to want to express here is there is increase in HIF, that is hypoxia inducible factor, because relative hypoxia is created because of the occlusion. Because of the occlusion, relative hypoxia is created, but it is not 100% hypoxia. You see, 100% hypoxia is not there. Anoxia is not never there. There is some amount of the hypoxia, and that's why BFR is relatively what is known as hypoxia-like situation, not hypoxia. The difference between hypoxia and hypoxia-like situation like BFR is, in hypoxia, there is a concomitant increase in HIF as well as another factor that is known as REDD1. REDD1 expression is there. The problem with the REDD1 is they have a negative role for the mTOR pathway. They have the negative role for the protein synthesis. That's why catabolic pathway is increased because of the activation of the REDD1 in hypoxia. Hypoxia. But however, in BFR, this REDD1 expression is not there. Then that negative effect is not there, but the positive effect of the HI1, that is HIF, that is what we call hypoxia inducible factor, is there. So we are having the positive effect, but we are not having the negative effect. That's why BFR is important. This paradoxical, relationship between HIF and because normally what is happening during the hypoxia, there is always, increase in HIF as well as REDD1, hypoxia inducible factor as well as REDD1, and REDD1 is having negative factor on the muscle growth, muscle protein synthesis. But in case of the BFR, the positive point, that is ISIF, which increases, whereas the negative point, which is the REDD1, is not increased. So this paradoxical relationship, because further research is required to explain why this is happening. There may be another third party, secondary messenger, another chemical messenger may be there because of all this happening. But the point is, BFR is useful. That's all. Chemically. So let's go again to the next factor. See, we already discussed this factor that because of the if we apply the PFR in the muscle, because of the different what you call the chemo mechano sensitive or chemo receptor mediated what you call the afferent nerve ending are stimulated, that is nerve ending 3 and 4, and these are these are nothing but the muscle pressure reflex, where they basically increase the sympathetic stimulation as well as they also increase the secretion of the growth hormone from anterior pituitary organ. So anterior pituitary, from the anterior pituitary, there is increase in growth hormone. This growth hormone act not only to the muscle of the our interest but also all over the body, and the growth hormone is known to increase the synthesis of the collagen, and collagen is very important for the muscle growth and all that stuff. Not only for the muscle but also growth hormone, they can go and act on the liver and lead to the production of the IGF-1 in this insulin-like growth factor. Like we have already discussed, there is increase in the IGF-1, and this IGF-1 is important for the ultimate what you call the activation, proliferation, and the stimulation of the satellite cell. And this satellite cell, the myogenic stem cell, which is important for the repair as well as growth of the muscle. So that's why the overall that's why this can explain what you call the hormonal, the distant effect, the systemic effect, because the release in growth hormone is everywhere. And one study, like we have already seen, the 290 times more increase in the growth hormone, supraphysiological increase in growth hormone concentration was in with the BFR reported by some of the author. So all this thing one has to understand. So let's see regarding the increase in the growth hormone, all this thing, like this, this was reported by Takano et al. In 2005. You can see that the this is the two group what they have seen is with the blood flow, BFR, without BFR, and you can see that this growth hormone plasma level of hormone keep on increasing. During just from the exercise to 10 minutes and the 30 minutes, even 30 minutes also. That means the important point, the beneficial effect is not restricted during the exercise. It extends beyond exercise for some time. It may be 30 minutes also, it may be beyond also. So at least for the 30 minutes they have reported. That is important. And also IGF, that is insulin like growth factor, also there is increase when you compare with this graph is showing what you call the upper one, that is darker one, is showing the exercise with the BFR, and this is without BFR. So with BFR, you can see that there is a statistical significant increase in what you call IGF. IGF again for the BGF, like we have already said, this is regarding the vascular endothelial growth factor. There is increase in vascular endothelial growth factor, and that increases. You can see the 10-minute also and the 30-minute also statistical significant increase was there. This is also accompanied with the increase in lactate threshold. What you call the blood lactate, and blood lactate has an important role. It is not only related with the, because one has to understand lactic acid. Always people has always correlated lactic acid with fatigue, but lactate has an important role to play in our body. It has a tropic effect also. It is one of the important fuel fuel source for the muscle as well as the other cell. By Cori cycle, it can be converted into glucose, the gluconeogenetic effect, as well as different secondary mechanism the lactate can play. Therefore, the lactate is also important. And when you see when control in the experimental group means BFR. Along with the BFR, you can see that as compared to the control group, significant increase in the blood lactate concentration is there. You can see here, and that increase is persistent. Persistent for some time after the exercise, like for example, 15 minutes, 30 minutes, 45 minutes, 60 minutes also, and after 120 or so, there was relatively similar. That means the increase in growth hormone, the increase in insulin-like growth factor, the increase in vascular endothelial growth factor, as well as the blood lactate, is not restricted during the exercise. It may go beyond the exercise for some time also. That is important because all this have a tropic effect. They can influence the positive physiological adaptation. So going again to this thing, because of the so many release of the trophic factor which are systemic actually, which are not confined to that particular organ, and because of this systemic effect, you can see what is known as the proximal effect. Also, you can see the positive changes in other muscle where you are directly not occluding the muscle. Suppose if we are doing the bicep curl or the bench press, and you are occluding the upper arm, proximal upper arm. So distal muscle is the bicep. So you are directly affecting the bicep. But what they have shown in this paper by the Yasoda et al. 2010, they have basically seen increase in strength in the proximal muscle also, like in the pectoralis muscle also, like in the bench press. You can see that they have given the exercise at 30% of the 1 RM. 30 repetition, then 3 into what you call the 15 repetition. That is 30 repetition followed by 3 times of the 15 repetition, 15, 15, 15. So this is the classic protocol. And the rest duration what they have given is 30 seconds, and they have given twice a day for 2 weeks. This was the exercise which they have given with BFR, without BFR. Control is without BFR, and experimental group is with BFR. And after this duration, when they see when they evaluated the muscle strength in the form of the bench press 1 RM, you can see that there is a statistically significant changes, positive changes in the BFR group. That means improvement of the strength was happening proximal to the cuff, because cuff is basically tying on the it is directly affecting the bicep and other upper arm and arm muscles, but you are having the beneficial effect in the what you call the proximal muscle, the pectoralis muscle also, and which will ultimately lead to the improvement of bench press, because bench press has a contribution from other muscle as well, upper arm, like tricep and all these things. But in spite of that, it has also an important important contribution for the pectoralis muscle also and other muscle, and which are lying proximal to the occlusion point, and hence you can see that this approximately favor this proof that there is the systemic effect, there is the proximal effect, and the beneficial effect of the BFR is not confined to that particular muscle, but also to other muscle as well. So this phenomena is very important. Next, going to the BFR and the cardiovascular response. You have to understand the basic physiology. Why understanding is important? Because if you understand the basic physiological response for the BFR, you will be able to better judge whether a particular candidate or particular client is suitable for BFR or not, whether there is some contraindication to BFR or not, whether you have to do certain cautions or not, because BFR will definitely increase heart rate and blood pressure. Like for example, if you see here during the exercise, this is a normal cardiovascular adjustment to the exercise. There is the role of the autonomic nervous system which is happening during the exercise. Normally the central command is there. Central command is there, mass sympathetic discharge and central command is always there. Apart from that, there is also important point is the exercise pressure reflect, like we have already talked, like group 3 and the group type 3 and a type 4 fiber. Type 3 is basically the mechano receptor, and type 4 is basically the metabo receptor. That is like for example, type 3 is stimulated by different proprioceptive joint movement, proprioceptive sensation, mechano sensitive fiber, and this one is basically stimulated by different metabolite, like with maybe hydrogen ion, that is intracellular muscle intracellular, what we call acidity, that is decrease in pH, or hydrogen, it may be because of the other potassium ion, potassium and other metabolite. So all these metabolite will lead to the activation of the type 3 and type 4 fiber, and we have seen that this will causes ultimately to the sympathetic discharge over the body. We have already seen that this type 3 and type 4, they are also responsible for the release of the growth hormone, systemic effect of the BFR. And also apart from that, there is a systemic stimulation of the sympathetic nervous system. And the important point is the baroreflex, which we are having normally operating, like carotid baroreflex and aortic baroreflex, they are basically overridden. That is there is a resetting of the baroreflex happening. They are not able to, because during the exercise, what is happening? There is increase in blood pressure, there is increase in heart rate also. The baroreflex is not working here. Why they are not working? Because of the central command, because of the exercise pressure reflex, because of all these factors, they are overriding basically the what you call the response of the baroreflex. That's why there is the sympathetic increased discharge there. Because of that, there may be increase in the heart rate, stroke volume, and the cardiac output is increased during the exercise, and there may be decrease in the parasympathetic outflow, and also in the because of the increased sympathetic supply to the adrenal medulla, different hormones will be released. Adrenal medullary activation will also be there, like RAS activation is there, renin angiotensin system, adrenaline, noradrenaline activation will be happening, and the sympathetic system directly to the blood vessels. Because of that, there may be increase in the arterial as well as the venous vasoconstriction will happen, and because of that, TPR, that is total peripheral resistance, or the increased peripheral vascular resistance will happen, which will ultimately lead to the increased rise in the systolic blood pressure, because systolic blood pressure is directly dependent upon cardiac output. Cardiac output is the major determinant of systolic blood pressure, whereas the total peripheral resistance is the determinant for diastolic blood pressure. So diastolic blood pressure as well as systolic blood pressure will rise, and because of that, both the mean arterial pressure will also rise. That means during the BFR, if you do BFR, increase in sympathetic discharge will be more as compared to the exercise without BFR. Now this you can see from this graph also. Like for example, this is the Oliveira et al. In 2019, they have proposed that if you do exercise without free flow exercise and BFR exercise, you can see that the increase in systolic blood pressure was high. That's increase in systolic blood pressure were more. When you do what you call exercise with a BFR as compared to the exercise without BFR. Similarly, for diastolic blood pressure also, the increase is relatively more, slightly more as compared to the exercise without BFR. That is free flow exercise. Normally, what is happening is systolic blood pressure always rise with the intensity of the exercise. If you do increase intensity, then systolic blood pressure rises in case of the both isotonic as well as isometric exercise. But diastolic blood pressure during isotonic exercise, comprising of the major large muscle group, what is happening is the diastolic blood pressure may remain the same. It may slightly decrease also, even if it increases, then it will be very slight. Why? Because of the what you call the exercise related local vasodilatory effect is happening, because you see, because of the different metabolite, there may possess the what you call the vasodilatation happening during in the active exercising muscle. Because of the TPR, total peripheral resistance, may may remain the same, it may decrease also, it may slightly, even if it is increased, then it is very slight. Because of the diastolic blood pressure approximately remains the same in case of the isotonic muscle, but in case of the isometric, diastolic blood pressure also rises. But here, when you do the BFR training, you can see that the rise in the diastolic blood pressure was more in case of the BFR, and it was not so in case of the what you call without the BFR. And the similarly, they have also they have also proposed, they have also mentioned this author, that is Tanaka Takano et al. 2015. They have reported different parameters which are related to the cardiovascular system. Like cardiac output here was, if you see the two group where this is plus means with BFR, this is without BFR, you can see that when during the exercising as compared to the rest, the cardiac output increases. In case of what you call the increase in cardiac output was more in case of the BFR. This is because of the sympathetic activation. Because of the sympathetic activation, cardiac output is increases. But the point is, stroke volume is not so increases. But when you see as compared to the resting condition during the exercise, for the BFR, without BFR, this is basically decrease in stroke volume is happening, because you are applying the tourniquet, and because of the tourniquet, venous outflow is restricted, and since venous outflow is restricted, then it cannot go, and the venous return will be reduced, and a venous return is a major determinant for end diastolic volume, and stroke volume is basically end diastolic volume minus end systolic volume. That means diastolic filling is not so there. That's why stroke volume decreases in case of the BFR. But since cardiac output is stroke volume into heart rate, because of the excessive increase in the heart rate, because of the sympathetic stimulation, the decrease in stroke volume is compensated by increase in heart rate, resulting into the increase in cardiac output in case of the BFR. In the same way, TPR also, if you see, the TPR is slightly, it may slightly decrease or it may remain the same. The TPR is basically remains the same. It is not so, because during the exercise, we already know that there are vasodilatory effect and all that stuff. Local, because of the TPR may remain the same, or slightly little bit difference is there. But for all practical purpose, it does not rise. It does not rise in spite of having increased sympathetic stimulation. And regarding the LVET, that is left ventricular ejection time, we can see that in left ventricular ejection time decreases as compared to the resting time. That means the heart is contracting very fast, the heart rate is increasing, because of that LVET time is decreases there. Both decreases is there for both BFR and the non-BFR, but it was more in case of the BFR. The point to be noted, the statistically changes is only seen in the cardiac output, LVET, as well as the stroke volume, and it was not seen in case of the TPR. There is no statistically different changes. That means during the exercise as well as resting, it was similar, statistically similar. And the increase in cardiac output is majorly because of increase in heart rate. This is important. But one has to understand the relationship, interesting relationship between the heart rate and the cardiac output, stroke volume. Ultimately, what is happening is, if the increase in heart rate is so much, if excessive increase in heart rate happens, then what will happen? The diastolic time will be decreases, and because of the decrease in diastolic time, the heart is not able to receive the blood which it normally receives during the diastole, and because of the stroke volume will ultimately decreases because of the decrease in end diastolic volume. So that's why the heart rate, the increase in heart rate will increase the cardiac output up to a certain extent. After, if excessive increase in heart rate is there, then ultimately it will be the cardiac output will fall. So this one has to understand also. But what this author has reported is increase in heart rate leading to increase in cardiac output in spite of the decrease in stroke volume. This is one has to understand. And and since there is increased heart rate, increased systolic blood pressure, and all that stuff, so there is a comprehension, fear of blood flow, use of the blood flow resistance training in case of the hypertensive, in case of the patient who are coming from cardiovascular illness, abnormality. So this study was, they have basically done in diagnosed case of the hypertensive females, but they have excluded, those who are more than equal to or more than 160 systolic blood pressure and 105 diastolic blood pressure. So this is the exclusion criteria. And they have done what you call exercise. This is a wrist flexion exercise, and blood with or without blood flow resistance training. and control where nothing was done. And they basically done 2 exercise session per week for 8 weeks, and blood flow reduction was done around 70% of the systolic blood pressure. 3 set of exercise was done with 30% of the 1 RM, and 30-second rest was given. And for and exercise risk what you call flexion exercise without BFR, they basically done at a very high load, that is 80% of 1 RM. BFR was done at 30% of the 1 RM, that is low load. But without BFR, the exercise was done at 80% of the 1 RM, that is high load. So here you can see that the changes are happening. This is from left to right. You can see the systolic blood pressure, diastolic blood pressure, and a mean arterial pressure. So systolic blood pressure, you can see that this is the reflection blood flow direction trend. So by giving the blood flow direction training, you can see that systolic, diastolic, and mean arterial pressure decreases. That means improvement was seen in the what you call blood pressure also. So because of the different nitric, it may be nitric oxide induced, or it may be other beneficial effect. It may be vascular VGF growth factor. Because of all that thing, because of the beneficial effect, there is a reduction in improvement in changes in blood pressure was seen. This is for control. Control, not much was seen. In fact, the increase was there in case of the systolic blood pressure as well as for mean arterial pressure. But in case of the exercise only, if you are doing elbow flexion, if you are doing elbow flexion only, what you call wrist flexion, sorry, if you are doing wrist flexion only, then what will happen? Your diastolic blood pressure may, in fact, no change, or it may be increase also diastolic blood pressure. Mean arterial pressure, not much change, but there was still a decrease in systolic blood pressure. But the decrease in systolic, diastolic, as well as mean blood pressure was statistically significant if you do as a low load plus BFR. So this is the importance of the BFR training. Similarly, what they have also reported for what you call heart rate and the DP. What is DP? DP is double product or red pressure product. Red pressure product, double product is basically the systolic blood pressure into heart rate. This is the indirect measure of the oxygen consumption by the heart. That is how much oxygen your heart is consuming, or what is the oxygen metabolic load of your heart, or how much your heart is working. So indirectly, by knowing the DP, double product or red pressure product, you are able to know this thing. So you can see that this is this thing. You can see that the heart rate was increases. This is the heart rate. This is a DP. Heart rate was increases in case of but the increase was relatively less. When you do blood flow, low intensity blood flow. But if you do only high intensity exercise, there was more increase in heart rate as compared to the increase in heart rate by blood flow resistance training. But the point to be remember is DP, double product. Double product is very important because it basically tell you about the oxygen consumption by the heart. That is oxygen metabolic demand of the heart. And you can see that there is decrease in double product, and this decrease in double product is mainly because of the decrease in systolic blood pressure. Because double product is basically systolic blood pressure in the heart rate is relatively higher. But since too much decrease in systolic blood pressure was there, because of that, what is happening is the double product decreases. That means your heart efficiency of the heart increases. Your heart is able to perform more, and your heart is utilizing less oxygen as compared to you are doing exercise only, or you are doing nothing at all. If you do nothing at all, then your double product will also increases, whereas your the changes and whereas your heart rate will also increase. But if you do exercise, at least double product was not so high as compared to the control. But the maximum benefit was seen in case of the blood flow resistance training. And they have done only at 30% of the RM. That's all for 8 weeks. 2 exercise sessions per week. This is important. So let's go into the different reported evidence where blood flow resistance training has been combined with different type of the exercise, like for example aerobic exercise. So let's see whether blood flow resistance training give to the improvement in the different aerobic parameter or not. This was reported by the Taylor et al. 2015. Here you can see this is a VO2 max. VO2 max is the aerobic capacity. That is maximum oxygen consumed. That is the gold standard for aerobic fitness. Here you can see that, and they have basically done in case of the cycling. And this is the control group, and this is a BFR group. The control group. This is a pre and post. This is pre and post. pre and post, and this is a BFR group. And you can see that what they have done is they have done what is called sprint interval training, SIT, with or without blood flow resistance training. And 4 week of SIT was done, and BFR was for what they have basically done is BFR in recovery. Spelling mistake, sorry for spelling mistake, RECOVRY. That is passive. What they have done is they have done BFR not during the exercise, not during the cycling, but after completion of the cycling, during the recovery period, for the first 2 minutes, they have basically done the BFR, that is blood flow restriction, and they have done restriction by using the occlusion pressure of 130 millimeter of mercury. So this is the thing, and you can see that there was statistically significant increase in VO2 max was seen. VO2 max was seen in case of the BFR group, but not in case of the control group. See, everything was same. The only thing was they have done is during the recovery they have just do passive BFR for just 2 minutes. That's all. So, but just by doing their thing, they are able to achieve. They are able to achieve. They were able to achieve increases statistically increase in VO2 max. But however, if you see the 15-kilometer time trial performance, but it was not so significant. That means increase in VO2 max was not translated in case of the what you call performance. That performance parameter were similar, comparable, like 15-kilometer time travel was comparable. But important is VO2 max was increased, because VO2 max aerobic fitness is more important for recovery also, not only for the performance, but also for the recovery. You will be able to recover as fast as possible if you have high VO2 max. So all this thing is important, because performance it's not only dependent upon a VO2 max. For performance, you require what you call the percentage to be utilized from the VO2 max. That is the lactate threshold or an anaerobic threshold. It's basically more important, and also exercise economy. How much you are able to perform exercise at a particular lower oxygen consumption. That is also more important. Economy of the movement, technique is more important. So VO2 max is not only the determinant. So here they said that performance is relatively same, but VO2 max. Similarly, another one. Here you can see that it was also reported by Michael et al. 2019. You can see that just by adding sprint interval training, they have added the blood flow resistance first 2 minutes in recovery. The same thing, first 2 minutes passive this thing. They were a cyclist or a triathlon. 4 weeks of the SIT was with or without blood flow resistance training was given. 4 weeks, 4 weeks of SIT, just like this one, similar. And here you can see that this is the pre and post, the control group and a BFR group. And you can see that in case of the VO2 max, there was statistically significant increase in VO2 max was seen in case of the BFR group. That means passive BFR. You are not applying BFR during the exercise, but only during the recovery. That is first 2 minutes of the recovery. But no improvement in training was seen. That means if you see the critical power is important for performance and all that stuff. And critical power, if you see there is improvement was there, both in case of the BFR, in case of the no BFR, improvement was there, but the improvement, there was no statistically significant difference between the BFR as well as non-BFR group. That means both critical power was improved, but there was no difference. But VO2 max was increased, and the BFR they have used is 120 millimeter mercury. Here they have used 130 millimeter mercury, and here in case of Michael et al. 2019, they have used 120 millimeter mercury. That's why. So what we can get from this is the aerobic training BFR by using passive BFR during the recovery, you may be able to achieve more VO2 max. But the thing is that may not be translated in your performance. This is also there. And here another study you can see there is also VO2 max. It was they basically done this study in board and indoor rowing training study, and they basically apply the BFR for a lower intensity means less than 2 millimole per liter of lactate, blood lactate. So this is basically a low intensity training where they basically use the blood flow during the low intensity training. That is, here they are using during the exercise. Okay, earlier they were using during the passive phase. Here they are using during exercise, and their exercise is done 3 times per week for 5 weeks. They have done, and blood flow is there. They generally they have applied the blood flow during the lower limb, and accumulated total blood flow what they have given is 1 hour per week, and occlusion per session was 2 times 10 minutes per session. So this is the occlusion which they have applied, and they basically do the occlusion at a lower intensity, and they basically have seen the comparison of the view autonomy. That is this is y-axis, this is the oxygen uptake, this is the x-axis, the pre and a post training, pre and a post training session they have done, because they have done exercise training for 5 weeks with and without what you call BFR. Control is without BFR 15 n equal to 15. Intervention is with BFR n equal to 16. You can see that in case of the intervention group, there is the statistically significant effect size. You can see that means 9.1%, approximately 9% increase in VO2 max was there in case of the BFR. So this is important. But in case of the non-BFR, not much was effect size. Effect size was only 0.3. 0.3 was the effect size. Approximately only 2.5% increase was there. Increase was there, but there was not statistical significant. It was not statistical significant. Plus, here it is very, very significant. That is less than 0.001. That is 9.1 or a 9% improvement in VO2 max was there. And also, if they have seen from the aerobic power also, maximum aerobic power was also increased by 15%. Here it is not shown. In another graph, they have shown that the maximum aerobic power was improved by 15%, whereas VO2 max was improved by 9%. That means it is very certain whether you use BFR during the recovery, or during the low intensity exercise, low intensity aerobic exercise like boat and indoor rowing training, then there will be improvement in the VO2 max is always there. This is important. So aerobic training with aerobic training, this is the forest plot for a meta-analysis which was published, and in this meta-analysis, you can see that it was published in 2015. You can see that by using aerobic training plus BFR, there was improvement in what you call the muscle strength also, and a mean muscle strength improvement of the 0.4 Newton, Nm was there. So in case of the muscle strength, in case of muscle size also, there was also significant. The significant improvement may be 0.32 centimeters square if you combine aerobic plus BFR plus aerobic exercise. Muscle growth will also be there, and here you can see that it favors the muscle growth. This is diamond shaped this thing. If it is going this side, that means it favors the intervention. Intervention means BFR plus aerobic exercise. Here also you can see that. So muscle strength, improvement is muscle strength is there with the aerobic exercise also plus BFR. So and a mean improvement was 0.4 Nm. In the same way, mean increase in muscle size was 0.32 centimeters square. This is therefore blood flow resistance training with aerobic exercise not only improve VO2 max but also improve muscle strength as well as muscle size. Now let's go into the another component where you do passive blood flow resistance training. Like I've already explained you in case of the increase in VO2 max. They have just applied the BFR during the recovery period, no exercise. So this concept of applying passive applying BFR without any exercise, this is known as passive BFR, and it has been used to in various occasions also. Like for example, here in this case, this author, Takarada et al. 2000, they have reported they have used post ACL reconstruction knee immobilization brace. They have basically see whether cross-sectional area, whether there was decrease or preserved muscle atrophy was there or not. They have basically seen by using blood flow resistance training. Blood flow resistance, they have given approximately 180 millimeter mercury, ranging from or it may be maximum to 200 to 260 millimeter mercury for 5 minutes, and then 3-minute release was there. 5 minutes they have maintained that, then 3-minute release was there, then 5 sets per session, and they have done 2 sessions per day. That means it may be morning and evening, something like that. It may be duration maybe 5 hours or 6 hours, 4 to 5 or 4 to 6 hour gap must be there in case of the 2 sessions, because twice session was there, and in one session 5 sets are there, and each set 5 minutes of BFR plus 3 minutes of rest. So this is a protocol which they have done, and they have compared the muscle cross-sectional area between day 3 and the 14th day after post ACL reconstruction in knee brace, and these are the what you call n equal to the sample size is 8, n equal to 8, and out of which 4 are males, and you can see that they basically done from knee extensor and flexor. Knee flexor and extensor. Knee extensor is basically quadricep, knee flexor is basically hamstring. So, and this is the total cross-sectional area. So you can see that statistically significant was there, in case of this is for day 14. So when you compare for experimental group where blood flow resistance training was done, see, decrease in cross-sectional area is relatively less as compared to the control group. That means preservation of the muscle mass, decrease muscle atrophy. You are able to preserve the muscle mass. You are able to decrease, the rate of the atrophy or the amount of the atrophy just by applying passive blood flow resistance training. This is important because you are able to preserve the muscle. Similarly, you can see that this is the total cross-sectional area, and this is the for the quadricep, that is the knee extensor, this is for the flexor. See, statistically significant was there if you compare, as compared to the day 3 here also. But in case of the control group, what is happening? More decrease was there. More decrease was there. More decrease in the total cross-sectional area, more decrease in the extensor, more decrease in the flexor. See, if you see the flexor and extensor, there was more reduction in muscle mass, more atrophy was there in case of the quadricep extensor as compared to the flexor, that is hamstring. But however, if you apply the blood flow resistance training, both hamstring and the quadricep relatively less decrease, and the decrease was same, relatively similar in case of the quadricep. This is important. That's why just by applying blood flow resistance training, this is important for early start of the rehabilitation, early return to the play, return to play or return to activity, return to sport. So we have already seen the importance of the passive BFR. There is BFR without using any kind of exercise, especially for the preservation of the muscle mass, for ACL reconstruction. Another important point which was reported there, which tells you about concern with the protein synthesis here, is the BFR alone. If you are doing BFR alone without any kind of the exercise, then what will happen? If you see the myofibrillar protein synthesis, there is FSR. FSR is the myofibrillar, fractional synthetic rate, protein synthetic rate. It was measured over, what we call 0 to 5 hour period after the low load resistant type exercise combined with or without exercise for a leg, BFR leg. And you can see that the protein synthesis rate was similar with the resting condition if no exercise was done. And this is the individual data. You can see that there is no statistical, this is different, and both are comparable. That means the protein synthesis rate for at a resting level without any kind of the BFR, and if you do only BFR, it was similar. Only and only statistically significant increase in protein synthesis rate was happen if you combine BFR with low load resistant exercise. That means exercise is important as far as protein synthesis is concerned. And this is the individual data. You can see there here in this graph, where in case of the y-axis we have the myofibrillar protein synthesis, FSR, percentage per hour by age. You can see that this is basically the myofibrillar protein fractional synthetic rate, that is FSR, and this is the individual one, and low load resistant type exercise they have done, and you can see the statistically significant increase in what you call protein synthesis is there, where it is not so there if no exercise was done. So that means, what is the take home point as far as protein synthesis rate is concerned? Exercise is extremely important. You cannot achieve that by using only BFR. That means apart from the metabolic tension, some amount of mechanical tension is important, because only BFR will cause metabolic tension, and because of that metabolic tension, maybe the protein and other the part of the musculature, they may be what you call more sensitive to the mechanical tension induced by the even a small amount of exercise. Because of that, there may be increase in the protein synthesis. That's why a combination of the mechanical as well as metabolic tension is required. Only and only metabolic tension in the form of only BFR, passive BFR, you will not be able to achieve the protein synthesis. This one has to understand. Again, what about the protein? What about the passive BFR accompanied with neuromuscular electrical stimulation? Because this has been used commonly nowadays, where electrical stimulation they mimic the exercise. Like for example, in this study which was done on 8 male, in case of the quadricep exercise, it was reported in 2015 by Natsume et al. And you can see that they have applied the neuromuscular electrical stimulation for 23 minutes, and that mimic low intensity, that is 5 to 10% of the maximum voluntary contraction of the quadricep muscle. They have mimic it, and it was done twice a day 5 days per week for 2 weeks, and 2 week was the 2 week they perform this training, and for another two week they have not done anything. That is a detraining week, and NEMS was given at a frequency of the 30 hertz, 8 second of the stimulation with 8 second of the pause. And BFR was given, for a 5 minute, 5 minute of 4 times, 5 minute set of the 4 times, and 1 minute rest interval was given. And the occlusion pressure was basically based upon the mid thigh circumference, because mid thigh circumference is the major determinant for the occlusion pressure. And for the person, or for the one who are having less than 50 centimeter mid thigh circumference, they have basically used 140 millimeter of mercury. For 50 to 55 centimeter, they have used 160 millimeter of mercury. For more than 60 centimeter mid thigh circumference, they have used 200 millimeter of mercury. This is the one, and this is the dark square. They are the BFR plus NEMS, that is electrical stimulation plus BFR, and white, the open square, it is the without a BFR, that is electrical stimulation is there without any kind of BFR. And you can see that during the training interval, you can see that the increase in muscle thickness, you can see muscle thickness in the form of in unit of mm, that is millimeter, and you can see that there is increase. And in the detraining phase, the decrease is also less as compared to what you call without any BFR. The slope may be relatively same here, so the rate of the decrease may be same. But the point is, since you have already achieved a higher muscle thickness, and during the detraining itself, during the detraining also, the muscle thickness was higher in case of BFR plus neuromuscular electrical stimulation. Similarly, for the isometric strength also, this is the graph for the isometric strength reported by the same author. And you can see that the y-axis is the isometric strength in NM, and this is the training for 2 week of training, 2 week of detraining. And you can see that in the experimental group where neuromuscular stimulation is combined with the what you call the BFR, you can see that there is increase in isometric strength is increasing. Isometric strength increases there, and since increases there, so during the detraining also, the strength was relatively higher. The strength was much higher as compared to the control group where BFR was not performed. The rate of the decreased slope may be relatively same. The point is, during the detraining, it is still higher. In the experimental group, they have achieved more strength, so they can lose also more. And during the detraining also, the strength was still higher as compared to the control group. That's why low intensity neuromuscular electrical stimulation with BFR induce muscle hypertrophy here, muscle hypertrophy and muscle strength gain. Strength gain in untrained young male participant. So untrained young male participant, because they have basically done in 8 untrained male participant, and hence the BFR with NEMS is a one of the important feasible option which you can do in your practice, especially post-operative, or in case of the immobilization also, because it is better than doing NEMS alone. This point one has to understand. So next, go into the, after understanding all these different concept of the BFR, where BFR leading to the different potential secondary chemical messenger which are important for the adaptation for what you call the physiological positive adaptation, all these things. So after understanding all these things, we can generate a hypothetical graph where the training adaptation with a BFR, with a time duration of the training, you can actually predict. And this was this hypothetical graph was given by Chris et al. In 2021. And here you can see that in the y-axis there is a training adaptation percentage of changes from the baseline, and you can see that they have done for untrained and a trained person also. This is trained person. Dotted line is dotted line is a trained person, and the straight line without any dot, a continuous line, is for the untrained person. So, and this one red line is for the what you call the BFR plus training, and the blue line is for BFR, no BFR, only training itself. So you can see that for the graph, for this, for example, for the untrained person, you can see that for the first, say, up to 8 weeks, up to 6 weeks, 2 to 8 weeks, 2 to 6 weeks, you can see that the increase in training adaptation, the percentage change from the baseline was much higher if you combine the training with BFR, especially for the untrained person. For the trained person also, the improvement was relatively less as compared to the untrained, but still improvement was there, when BFR was added. Still, you can see that this dotted red line is much higher as compared to this dotted blue line where BFR is not combined. mind. That means BFR, at least for up to the first 8 weeks, the first duration of the training, BFR is an important supplementary training which you have to add, in to your player, whether it's untrained, whether it or whether it is highly trained. Still some benefit you can get, at least for the first few weeks of the training. So this is a hypothetical adaptation for illustration of the training adaptation which is shown, and here you can see that the addition of the BFR may accelerate the adaptation at the onset of the training in both scenario. In both the scenario, it may be trained, it may be untrained, and because of the addition of the BFR, you can see that the improvement is much higher, but the magnitude and the timeline may differ. It depends upon the different person. Individuality is also there, and the fading of the line and the question mark here in this point, because not much data is there, we don't know much about it, indicate that less is known about the temporal response to the training with or without BFR for a prolonged period. That is, after 8 weeks, we don't know whether addition of the BFR will have the additional benefit or not, or whether BFR has a still a positive role to play or not. We don't know. But the thing is, what we know is for the initial part of the training, up to say 6 weeks or 8 weeks, BFR has an important role, especially for untrained person. This one has to understand. And the BFR, you can give the BFR in a form of different form, like it may be continuous BFR, it may be cyclical BFR. In case of the continuous BFR, you are continually applying the BFR. In case of cyclical, you are releasing, you are maintaining pressure and then releasing, depending upon, like, for example, this is the continuous one, exercise is there plus exercise plus BFR is there, or this is the what you call only exercise, or the BFR, cyclical BFR, you can apply, and it can be combined with a different form of the exercise, whether it may be strength training, whether it may be weightlifting, whether it may be aerobic form of exercise, like walking, it may be jogging, or it may be cycling. So different exercise in different intensity, duration, and frequency, you can apply the BFR. It may be continuous, it may be cyclical, and the exercise mode may be cycling, running, it may be walking, it may be running, it may be cycling, it may be depending upon what you require. And the most important point is, for the initial duration up to 6 to 8 weeks, the definite positive adaptation will be there. That is the importance of BFR. That's why you should supplement, you should add your regular classic training with BFR. Addition of the BFR, as long as there is no contraindication, it's always beneficial for the first week of the training. Now, how much occlusion do we have to keep? This is another point which we have to understand. Now, this study one can easily done by using the near infrared spectroscopy, NIRS. Here you can see how much saturation is fall in saturation is there if you do without BFR or if you do BFR. Like, for example, bicep muscle, if you do bicep curl here by using the BFR, and this is without BFR, no BFR band was utilized, 25 arm curl exercise they have done, and this is the SMO2, that is the what you call skeletal muscle, what you call oxygen saturation, SMO2. And you can see that during the muscle contraction, the SMO2 will decreases, there is say up to how much, up to 30%, you may say, then it will increases, then it will cyclically flows like this. But the minimum fall was approximately 30, not beyond 30, not below 30. But here, in case of the BFR, you can go up to 10% also. That means if you do failure of exercise, if you don't release the exercise band also, then what will happen? You will continue the fall in SMO2. That means muscle oxygen saturation will be fall, and this hypoxia type situation, where you are say 100 millimeter mercury, in case of the 100 millimeter mercury, this must fall in saturation was there, 200, this must fall, like for example 400 millimeter mercury, you can have up to the fall of say 5 to 10 millimeter mercury also. 5 to 10% in SMO2 fall maybe there if you use 400 millimeter mercury. So in this way, if you keep on increasing the occlusion pressure, the fall in saturation, oxygen saturation will be there. That means the relative hypoxia is there, and this relative hypoxia is important for inducing various secondary mechanisms for the overall improvement of the skeletal muscle hypertrophy, muscle strength, and all the positive adaptation which we have already seen. And here in this example, we can see that this was reported by Reyes et al. In 2019. You can see that this is during the recovery 1, recovery 2, recovery 3. This is the TOI. TOI is the tissue oxygen percentage of recovery. This is the tissue what you call tissue oxygen recovery. How much tissue oxygen is there in case of the recovery? Tissue oxygen percentage of the recovery during the intercept interval. This is the basically this thing. And here is the no BFR. Is a 40% of the occlusion was there. Here no occlusion is there. Here it is the 60% occlusion was there and 80% of the occlusion was there. Let's see about the what happened to the tissue oxygen saturation. TOI is the tissue oxygen saturation. Here. And they basically done exercise by 4 set of the knee extension, that is quadricep exercise was done at 90% of the 1 RM. And basically they have done for first they have done for 30 set, 30 repetition, then 15 repetition, then another 15 repetition, and last is the 15 repetition. 30 50 50 30 15 15 15 set repetition, and set 1 to 4 for respectively with 30 seconds of passive rest between the set. In that set, the 30-second over rest was given, say rest 1 to 3. Okay, so this is the basically the protocol which they have followed, and the magnitude of the TI recovery was here. What we can see that let's see where is the star. Is this symbol indicate what? Star is significantly different from NOBFR. That means star means significantly BFR. That means only and only at 60 to 80% of the arterial occlusion, your tissue oxygen saturation was significantly lower as compared to no BFR. So if you do 40% of the arterial occlusion, then the decrease in tissue oxygenation was not similar. That means if you want to reduce your tissue oxygenation, then you should do at least more than 40% of the occlusion has to be done. This is the information which we get from here. Another point is this one. This was statistically significant from 40%. 40%. So 40% also see. 40%. That means at 60% of the AOP, that is arterial occlusion pressure, and 80% of the occlusion pressure, the reduction in TOI during the recovery, that is percentage, was statistically significantly less as compared to no BFR, and also as compared to the 40% also. But there was no significant difference between 60 and 80%. So what is the take-home message? Take-home message is if you want to reduce the tissue oxygenation, then you have to do arterial occlusion, which for in case of the what you call the quadricep, the knee extension exercise here in this case, at least more than 40%. 40, it has to be more than 40%. But if you have to choose between 60 and 40%, not much difference is there, because statistical difference between 60 and 40 is not there. So you can do 60 also, you can do 80 also, but 60 and 80 is important for having what you call the less tissue oxygenation in order to have that all that metabolic stress effect. But if you do 40%, then in this example, if you do 40%, then not much benefit was there. That means what they have shown is they support the use of 40 to 60% of the LLP. That is more than 40%. It has to be at least 40%. 40% of 40 to 60% of the limb occlusion pressure while performing BFR to maximize the oxygen stress, with no further benefit occurring at 80%. That means if you do more than 80, 90, 100, no benefit is there. More stress will be there. More heart rate will be increases. More systolic blood pressure will be increases. More problem may be there, but benefit will not be there as far as tissue oxygenation is concerned. So in order to maximize the oxygen stress, it is 50% or 60% is sufficient. You don't have to go higher, but 40% or less than 40% is not sufficient. Another study by ILET 2019, they have pointed out that 60% seems to be the sweet spot. 60%, because if you go beyond 60%, then because of the various cardiovascular responses, you may have problem. You may have side effect, maybe there, maybe more pain may be there. But if you do less than 40%, then no effect will be there, no oxygen stress will be there. So the sweet spot is around 60%. So this is the take home message of this one. But again, this is for different author has reported different distinct. But the point is, you can always reduce more, even you can reduce more than 40% also. If you are doing a relatively higher load, if you do relatively higher load, then you can still reduce the limb occlusion pressure further more also in order to have that oxygen stress. So it depends upon it. This is the one which this author has reported. It may not be necessary. You cannot apply this generalized this to all to everyone. This is also important. Like this protocol which they have given. This is the protocol which they have given, and in this protocol you can see that this was given by Het et al. 2021. And in this protocol, you can see that for upper limb and lower limb, what they have done is for occlusion pressure, they have fixed around 50% of the LOP is sufficient for upper limb. For upper limb, like if you are doing, if you want to do the bicep, if you want to do certain bicep and what you call the bench press and all that stuff, you can do 50% of the LOP is sufficient. But if you want to do what you call the leg press, leg press and all that squat and all that stuff for lower limb, approximately around 80% of the LOP they have used. This is the protocol which they have used. See, in the earlier paper, we have seen that 60 or 80% not much benefit is there, but still this author has reported. That's why it depends upon from author to author. It depends upon your experience also. That's why experience is more important. You cannot just apply all this protocol as such. You have to modify based upon your experience, based upon your clinical reasoning, based upon the status of the client, status of your subject, all these things. And the resistance intensity generally for the upper limb is around 30 to 50% of the 1 RM or maximum MBC, that is maximum voluntary contraction. For a lower limb, it is generally lower because the LOP is high, so intensity has to be low, and the intensity is 20 to 30% of the 1 RM is what they apply, or MBC. And it must be around 7 to 8 RP. That is rate of perceived exertion. 7 to 8 rate of perceived exertion should be the intensity. Another is the repetition per set, and this is the classic one, which we have already seen. 30 repetition followed by 15 repetition, followed by 15 and 15. 30, 15, 15, 15. 3 times 15 and 30. This is the classic protocol, which has been widely used in the field of the blood flow resistance training. And the rest given is also relatively less rest is given. Why? Because you want to maintain that metabolic stress. That's why only 30 seconds of the rest is given. It is similar for upper limb as well as lower limb. And the frequency 2 to 3 times per week you can do. Same 2 to 3 times per week. And duration, how much the exercise duration you can do up to say more than or equal to 8 weeks of exercise you can do. For the lower limb, you can do 8 to 12 weeks of exercise you can do. So this is important. This is one of the protocols which they have given. Apart from that, another protocol, the another author also, like Peterson et al. 2019, they have given this another protocol also. Here you can see that the frequency they have given a frequency of 2 to 3 times a week, and for effective more than 3 weeks or 1 to 2 times per day. That is for 1 to 2 weeks they have given for a general exercise protocol. The load may be 20 to 40% of the 1 RM, and a restriction time. They restrict how much. For how much duration you are going to restrict the blood flow. It may be 5 to 10 minutes, not much very high, not much very longer duration. 5 to 10 minutes per exercise can be done. Reperfusion is allowed during the exercise, between the exercise. And type of the exercise may be small in the large muscle group. It may be arm and leg, unilateral, maybe bilateral, maybe there. The set is 2 to 4 set can be done. Cuff, cuff, it depends upon the your cuff may be 5 small. The problem with the small cuff is you have to apply more pressure. More force has to apply, more occlusion has to be, more force has to be applied in order to achieve that same occlusion if you are using small cuff. And that's why a broader cuff is always preferred. The 5 small, it may be 5 centimeter, it may be 10 to 12 medium, or in the 17 to 18 centimeter large cuff may be there. So we generally prefer a medium or a little bit larger. A smaller one we don't do because of the pressure may be too high. Repetition pressure, repetition, it may be same 75 repetition can be done. It can be done similarly, same thing, the famous one, 30 into 15 into 15 into 15, 30 repetition followed by 15 repetition followed by 15, another 15 repetition, or the last one can be set to failure. It can be done to the failure also. If the 40 to 80% of the AOP, that is arterial occlusion pressure, if you are using 40 to 80% arterial occlusion pressure, the set can be led to the failure also. And the rest between the set is 30 to 60 seconds. It may be up to 1 minute, but generally less we always prefer, because we want to maintain that metabolic stress. Restriction form, it may be continuous or intermittent, depending upon whether you are using the intermittent BFR training or continuous BFR training. And there's execution speed, it may be, for example, 1 to 2 seconds. 1 second is for tempo, 1 second is for concentric part. If down eccentric part may be slow, little bit slower, that is 2 seconds maybe for eccentric part. So this is the tempo execution until concentric failure may be there. If you are not able to maintain the maintain, if you are not able to do concentric contraction, that is known as concentric failure. Or when the planned repetition is completed, like for example, if I do 30 into 15 into 15 and 15, that is after completion this I may stop the exercise. So depending upon whether failure is there or whether that particular goal is reached, depending upon that you can prescribe the blood flow restriction training. Similarly, this is a general rule of thumb we have used. Another rule of thumb what they can use, you always use a light exercise. Always muscle can be performed to the failure also, up to 10 to 20 minutes, maximum 20 minutes, say your BFR can be done. General protocol is 3 set of the, here they have used 15 to 30 repetition for 5 to 15 exercise. So 5 to 15 exercise consisting of the 3 set of 15 to 30 repetition you can do. And the classic is always 30 into 15 into 15 into 15, 30-second rest, 30 to 60-second rest. This is the classic one which we have used. So this is the another protocol for BFR, blood flow resistance training. Now let's go to the protocol for aerobic exercise. Aerobic exercise, blood flow, various protocol has been given, like this author has given this protocol. The occlusion pressure for aerobic activity may be 50 to 80% of the LOP, that is limb occlusion pressure, limb arterial occlusion pressure. This is the BFR. By applying the BFR, he is doing cycling, stationary cycling. And resistance or intensity may be at the 30 to 40% of the VO2 max. That means you are not aiming the very high intensity. If you are using BFR, don't do high intensity. Otherwise, side effect injury may be there. Because sometimes what is happening is many people, just in order to achieve the more adaptation, they just want to increase the load. BFR also, they want to increase the occlusion also, they want to increase the load also, they want to increase the duration of the occlusion also, they want to apply the occlusion in all four limbs, that is upper limb and lower limb. Very dangerous. You should not do like that. Because see, blood flow, you are restricting the venous outflow. Venous return has to be there in order for the heart to pump. Sometimes, many of the cases we have seen that during the blood flow restriction, many will syncope also. Many will goes into fainting, syncope. Because of the neurogenic mediated syncope may also happen. And petechial hemorrhage may happen. So many other side effect may happen. So that's why it's always better to do less occlusion, prescribe occlusion, less duration, accompanied with less intensity. Otherwise, what will happen? Muscle damage will be more. You will have more problem. More side effect will be there. So that's why it has to be 30 to 40% of the VO2 max. Time maybe 10 to 30 minutes. 30 minute up to 30-minute occlusion you can do. Frequency 3 to 4 times per week you can do. For how much duration training? Maybe say 6 to 8 weeks or more than 8 weeks also you can give. So this is the another protocol. Another protocol which is given by another author, that is what we call the Peterson 2019. The frequency, you can do frequency of 2 to 3 times per week. That is more than 3 weeks. You can give exercise for more than 3 weeks. Or if you are doing 1 to 2 times per day, then you can give up to 1 to 3 weeks of exercise. That means if you are increasing the frequency per day, twice a week per day, then don't lengthen the duration of the training. You can give up to less than 3 weeks. If you want to do more than 3 weeks, then you can the frequency can be 2 to 3 times a week only. That's all. This is important. Intensity less than 50% of the VO2 max or HRR, heart rate reserve. And 50% of the heart rate reserve, or 50% of the VO2 reserve, or 50% of the VO2 max. Restriction time may be 5 to 20 minutes per exercise. 5 to 20 minutes per exercise. Type may be large and small muscle group. It may be arm, leg, unilateral, bilateral. And the pressure may be continuous also, interval pressure also. You can give to 40 to 80% of the AOP. There is arterial occlusion pressure you can give. The cuff may be, like we have already said, small cuff is 5 centimeter, medium 10 to 12 centimeter, or 70 to 18 large centimeter cuff you can use. Exercise duration is cycling or walking. Cycling or walking you can do, or different type of exercise regimen you can do. All these things is important. and we always prefer a relatively larger, medium sized cup, not very small cup is not preferred. These things is important. So let's go to the protocol which they have given for the resting also. Like without doing any kind of the exercise, you can still get the benefit. Like we have already seen, as far as decreased muscle atrophy is concerned, we already seen that the blood flow restriction training without doing a passive blood flow restriction also some benefit is always there. We have already seen that. Okay.